1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Step onto any acute psychiatric unit, or honestly, like any high acuity medical floor, and you are just immediately confronted with the absolute chaos of human behavior.
Oh, absolutely. It is completely overwhelming if you don't know what you're looking at.
Right. I mean, you might have one patient who is entirely catatonic, just staring at a blank wall, and then down the hall, someone is screaming that the nursing staff is, trying to poison their food.
Right. And meanwhile, in room 3, you've got a patient recovering from a massive myocardial infarction, casually eating a cheeseburger and joking that their chest pain was just like bad indigestion.
Exactly. So if you're looking for a clean black and white explanation like, I don't know, a fractured femur on an x-ray, you are entirely in the wrong place. The diagnostic landscape of human psychology and emotional suffering is just incredibly murky.
Which is exactly why relying on a single psychological framework is clinically dangerous. I mean, if you try to treat the catatonic patient, the paranoid patient, and the patient in deep denial using the exact same theoretical lens, you will fail.
Yeah, that makes total sense.
Modern psychiatric treatment, and especially psychiatric nursing, operates on what we call an eclectic model. We synthesize the highest yield concepts from psychoanalytic, behavioral, cognitive, and interpersonal theories.
So we're kind of pulling the best tools from different toolboxes.
Exactly. To build a customized, safety-focused approach for the specific patient in front of us. And our mission today is to break down this eclectic toolkit.
I love that.
We are parsing out the mechanisms of human behavior to extract the top 20% of theoretical knowledge that will give you 80% of your clinical understanding. Whether you're, prepping for board exams like the NCLEX, stepping into a clinical rotation, or just trying to understand the psychological mechanisms driving the people around you.
So let's jump right in and look at where this eclectic model really started. Because modern clinical practice has evolved far beyond him, but the undisputed bedrock of psychotherapy is Sigmund Freud.
Oh, without a doubt.
We have to examine his deterministic view of the mind, which essentially argues that zero human behavior is accidental. Like, every single action, slip of the tongue, or unexplained physical symptom has an identifiable caused root.
Right. Freud built this theory observing female patients in the late 19th century who presented with severe somatic symptoms. We're talking sudden blindness, inability to speak, or complete paralysis of the limbs.
But with absolutely no underlying neurological or physiological damage, right?
Exactly. Medical imaging and diagnostic tests for these patients would be entirely clear. So Freud hypothesized that these profound physical manifestations were the result of deeply repressed trauma.
Usually childhood or psychosexual trauma, if we're talking about Freud.
Yeah, precisely. The psychological conflict was so unbearable that the mind literally converted the emotional pain into a physical deficit. And this concept of somatic conversion is highly testable and clinically relevant today.
Wait, really? We still see this?
Well, absolutely. When you assess a patient presenting with sudden, inexplicable neurological deficits, your priority nursing assessment obviously begins with ruling out organic causes.
Like checking for a stroke or a brain tumor.
Right. You always prioritize physiological safety first. But once physiological causes are ruled out, we rely on Freud's foundational concept. Severe psychological distress can and will hijack the physical body.
Wow. And that hijacking is orchestrated by the architecture of the personality, which Freud split into the id, the ego, and the superego, right?
You've got it. Let's break those down because they are crucial. The id is the primitive engine. It is entirely unconscious, driven solely by the pleasure principle.
So it's basically like a demanding toddler in a candy store.
That is the perfect analogy. It just demands immediate gratification of biological urges with zero regard for consequences.
Okay, and then the superego.
The superego is the internalized moral compass. It's the strict rule-following parent. It represents rigid societal rules and parental expectations that demand absolute perfection and conformity.
So they're completely at odds.
Entirely.
Mm-hmm.
And caught in the crossfire is the ego. The ego is the conscious mediator, bound by the reality principle.
So the ego is the stressed-out babysitter just trying to get the demanding toddler and the strict parent through the grocery trip without a meltdown.
Exactly. It has the incredibly taxing job of satisfying its primal urges without violating the superego's strict moral codes. And the friction between those three structures generates anxiety.
So when a patient's ego becomes overwhelmed by those conflicting demands, that's when clinical anxiety manifests.
Right. And Freud conceptualized the mind like an iceberg to explain how this anxiety operates.
Yeah.
The conscious mind is just the visible tip above the water, your current active thoughts.
Stuff we're aware of right now.
Exactly. Then the preconscious is just below the surface. It holds information you can retrieve with intentional effort, like recalling a phone number or a past clinical experience.
Okay, but the rest of the iceberg.
The vast, dangerous bulk of the iceberg is the unconscious mind. This is the repository for repressed traumas, socially unacceptable desires, and primitive drives.
And they stay down there because acknowledging them would just destroy the ego.
Exactly. They are actively locked away because they're too threatening. But those locked away traumas don't just sit dormant. They actively drive behavior from the dark.
Which is terrifying, honestly.
It is. Freud developed psychoanalysis specifically to bypass the ego's defenses and access that unconscious material. He used dream analysis, operating on the theory that when we sleep, the ego's guard drops, allowing unconscious fears to surface as symbols.
Like the classic phallic symbols everyone jokes about.
Right, though it goes much deeper than that. He also utilized free association, forcing a patient to respond instantly to prompt words.
To catch them off guard.
Exactly. The clinical logic is that speed prevents the ego from filtering the response, causing the true repressed thought to slip out. This is the origin of the Freudian slip.
Oh, I love the example from the source text for this. It's like if a patient is speaking to a heavier friend and they accidentally say, "You look portly today," instead of pretty.
Yes. Freud would argue the unconscious just bypassed the mediator. The true revolutionary weight of Freud's work wasn't necessarily his hyper-focus on psychosexual development.
Right, because a lot of that has been debunked or moved past.
Exactly. The real breakthrough was his assertion that irrational behavior is inherently treatable if you uncover the root cause.
But accessing that root cause is difficult, right? Because the ego is actively fighting you.
Yes, the ego deploys defense mechanisms to protect itself. And for anyone practicing in a clinical setting, recognizing ego defense mechanisms is an absolute necessity.
These are those unconscious, automatic psychological shields used to cope with unbearable emotional pain, right? Let's dissect a few of the most critical ones you will encounter on the floor.
Good idea. Denial is arguably the most common and a huge safety risk. This is the complete failure to acknowledge an unbearable reality.
So picture a patient who has just been diagnosed with end-stage renal failure, and they're actively eating a bag of heavily salted potato chips and telling the nursing staff they'll be ready to run a marathon next week.
Exactly. And the crucial thing for a nurse to understand is that they aren't lying. Their ego has completely blocked the reality of a diagnosis to prevent a psychological collapse.
Wow. So you can't just argue with them.
No, arguing reinforces the defense. You have to gently orient them to reality while supporting the underlying fear. Displacement is another high-yield concept you'll see constantly.
That's when a patient transfers intense, unacceptable emotions from the actual source onto a safer, less threatening target, right?
Exactly. Imagine a patient who receives a devastating terminal diagnosis from an attending physician. The patient cannot safely express their rage at the physician.
Because the physician holds their medical fate in their hands.
Right. So instead, the moment the physician leaves the room, the patient viciously screams at the nurse for bringing their water with ice instead of without.
Oh, I've seen that exact scenario happen.
We all have. The priority nursing intervention here relies on clinical judgment, recognizing that the anger is displaced. You do not take it personally, and you do not argue about the ice.
So you de-escalate using therapeutic communication aimed at the underlying fear.
Exactly. You seem very upset since the doctor left. Would you like to talk about what he said? That kind of thing. Then we have reaction formation, which involves acting in the exact opposite manner to your true unacceptable feelings.
Oh, like if a nursing student secretly feels overwhelming resentment toward a highly demanding clinical instructor, but acts obsequiously sweet and constantly praises the instructor to the rest of the cohort.
Spot on. That is reaction formation. They are overcompensating to bury the unacceptable resentment. Then we have sublimation, which is generally viewed as an adaptive, healthy defense mechanism.
That's substituting an unacceptable impulse with a socially acceptable one, right? Like sucking on hard candy to quit smoking.
Yes, or a patient with intense aggressive urges joining a highly competitive boxing gym. They're sublimating that drive into something productive.
Now, Freud believed these mechanisms become deeply ingrained during childhood through those 5 psychosexual stages: oral, anal, phallic, latency, and genital.
Right. And the clinical takeaway for nursing students isn't necessarily memorizing the nuances of each stage, but understanding the concept of fixation.
Getting stuck.
Exactly. Freud argued that if a child experiences severe trauma or unmet needs during a specific stage, their psychological development arrests.
So they physically grow into an adult, but their emotional coping mechanisms remain stuck at that earlier stage, leading to adult psychopathology.
Precisely. And that historical trauma inevitably leaks into the therapeutic environment through two of the most dangerous dynamics in clinical practice: transference and countertransference.
Okay, let's break these down, because isn't transference just a fancy word for projecting?
It's a specific type of projection. Transference occurs when a patient unconsciously displaces feelings, attitudes, and expectations from a significant figure in their past onto the healthcare provider.
For instance, a teen acting incredibly rebellious and hostile toward a nurse who resembles their strict parent.
Exactly. Or a patient with a history of a highly abusive, authoritarian father, unconsciously projecting that dynamic onto a male psychiatrist. They might become intensely withdrawn or paranoid, not because of anything the provider did, but because the provider's authority triggered that repressed dynamic.
Okay, so transference is on the patient's end, but countertransference is when the healthcare provider does it to the patient.
Yes, and countertransference is a severe safety red flag. This happens when the provider unconsciously displaces their own unresolved emotional baggage onto the client.
So how exactly do nurses or therapists prevent countertransference from ruining the treatment?
It requires intense, continuous self-awareness. Let's say a nurse grew up with an alcoholic parent who constantly manipulated the family. Now that nurse is assigned to care for a patient undergoing severe alcohol withdrawal.
Oh, I see where this is going.
Right. The nurse might unconsciously act with punitive coldness, ignoring the patient's pain because they're seeing their parent, not the patient. Countertransference destroys therapeutic boundaries and compromises patient safety.
So what's the mandatory intervention there?
Clinical supervision and self-reflection. Nurses must ruthlessly interrogate their own emotional reactions. If you feel a sudden, disproportionate anger, or, conversely, an inappropriate rescue fantasy toward a patient, you must consult a colleague and potentially step away from that patient's care.
That is incredibly practical advice. Now, Freud's psychoanalytic framework really laid the groundwork, but as we mentioned, it heavily neglected the cognitive and social evolution that occurs beyond adolescence.
Yes, it was very hyper-focused on early childhood.
Right, which demands a shift to the developmental theories. We have to look at Erik Erikson, a psychoanalyst who broadened Freud's scope into 8 psychosocial stages covering the entire human lifespan.
Erikson is foundational. He theorized that at each stage of life, an individual faces a critical psychosocial conflict. Successfully resolving that conflict yields a specific psychological virtue, but failing to resolve it leaves a prominent developmental scar.
Let's start at the beginning. The foundational stage is trust versus mistrust, right? From birth to 18 months.
Correct. The infant is entirely dependent. If caregivers consistently provide food, comfort, and safety, the infant resolves the conflict and develops the virtue with hope, the core belief that the world is a reliable, safe place.
And if they don't?
If the caregiver is neglectful, abusive, or highly inconsistent, the infant develops deep mistrust. From a clinical perspective, this early failure is heavily implicated in the development of severe personality disorders, particularly borderline and antisocial personality disorders.
Wow. So those patients who view every clinical intervention with intense suspicion.
Exactly. You cannot effectively teach or treat those patients until you establish a baseline of trust, which requires rigorous consistency and transparent communication from the nursing staff. Do what you say you're going to do every single time.
So as the individual moves through life, they hit autonomy versus shame in toddlerhood, industry versus inferiority in childhood, and identity versus role confusion in adolescence.
Yes, and Erikson pushes all the way to late adulthood with ego integrity versus despair, where an elderly patient reviews their life. If they find meaning, they achieve wisdom. If they see only failure, they fall into despair.
It's a really beautiful, comprehensive roadmap. But alongside Erikson's social roadmap, Jean Piaget mapped out the biological progression of human intelligence with his cognitive stages.
Right. Piaget wasn't looking at emotional trauma. He was looking at how the brain fundamentally processes reality. And his theory is paramount for pediatric nursing and patient education.
Okay, so let's go through his 4 stages. The first is sensoromotor, birth to 2 years.
That's where infants learn object permanence, the understanding that an object still exists even when hidden.
Like playing peekaboo.
Exactly. Then comes the pre-operational stage, ages 2 to 6. This is characterized by rapid language development and symbolic thinking, but the child remains highly egocentric. They cannot conceptualize another person's perspective.
Okay, then concrete operations, ages 6 to 12.
This introduces logical thought, but only regarding physical, tangible objects. Abstract concepts remain totally out of reach.
And finally, formal operations, from 12 onward, which allows for abstract reasoning, hypothetical thinking, and cognitive maturity. But I have to push back a little here.
Oh, for it.
Piaget's theory suggests cognitive maturity is reached by middle to late adolescence. Is cognitive development really that rigid? What about adult brain development?
That's a great point, and modern neuroscience heavily critiques Piaget on this. We now know that the prefrontal cortex, which governs executive function and impulse control, does not fully myelinate until the mid-20s.
So cognitive development is much more individualized than Piaget suggested.
Exactly. But let's apply Piaget directly to clinical judgment anyway, because it's still highly testable. If you are a nurse tasked with explaining a bone marrow biopsy to an 8-year-old patient,
You can't use abstract statistics about survival rates, right?
exactly. An 8-year-old is in the concrete operations stage. They process reality literally. You must use physical models, simple analogies, and tangible equipment they can touch. If you try to teach an 8-year-old using the cognitive approach meant for a patient in formal operations, you'll induce massive, unnecessary anxiety.
That makes total sense. Now, those internal developmental clocks are constantly influenced by the external environment, which brings us to the interpersonal theories.
Yes, this is the realm where psychiatric nursing truly found its independent identity.
Starting with Harry Stack Sullivan. He believed that human personality is almost entirely forged in the crucible of interpersonal relationships, right?
Right. He argued that the root cause of all clinical anxiety and emotional suffering is inadequate or toxic social interactions. If your relationships are shattered, your psyche is shattered.
And he coined the term participant observer for the therapist's role.
Yes. Prior to Sullivan, psychiatrists often functioned as detached, objective scientists observing a specimen. Sullivan argued the provider is actively influencing the therapeutic environment simply by being in the room.
He also helped develop the therapeutic community, or milieu therapy, right?
He did. By treating young men with schizophrenia in a controlled, supportive ward, he proved that the environment itself, patient-to-patient interaction, structured routines, shared responsibilities, is a powerful healing modality. The therapeutic community forces patients to practice interpersonal skills in real time.
Which is foundational to modern inpatient care. And that leads directly to Hildegard Peplau. She built on Sullivan's work to create the therapeutic nurse-patient relationship.
Peplau is widely considered the mother of psychiatric nursing. She structured this relationship into 4 distinct sequential phases: orientation, identification, exploitation, and resolution.
I always compare Peplau's stages to a classic movie script structure.
Oh, let's hear this.
Well, orientation is the setup. The nurse and patient meet as strangers. Identification is the team-up, where they agree on the problem. Exploitation is the action montage, where the hero actively uses their new skills. And resolution is the emotional goodbye.
That is actually a brilliant way to remember it for exams. The orientation phase is the bedrock. The priority in nursing action here is establishing boundaries, clarifying the patient's problems, and defining the scope of the relationship. This is where you build the contract.
And then identification is when the patient begins to trust the nurse, expressing their feelings and recognizing the nurse as an ally.
Right. Then we enter the exploitation phase. The patient is fully engaged, actively utilizing the healthcare services, practicing new coping mechanisms, and fluctuating between dependence on the staff and newfound independence.
And finally, resolution brings it to a close. The patient's acute needs are met, they abandon old behaviors, and the therapeutic alliance terminates.
Exactly. Peplau also defined the various roles of the nurse within this relationship: stranger, resource person, teacher, leader, surrogate, and counselor. But her most critical contribution, arguably, was how we understand and manage clinical anxiety.
Yes, she categorized anxiety into 4 escalating levels: mild, moderate, severe, and panic.
And mastering these 4 levels is non-negotiable for safe nursing practice, as your interventions must radically shift depending on the patient's state.
Let's break them down. Mild anxiety is a normal adaptive state, right?
Yes. Senses are sharp, motivation is high, and the perceptual field is wide. This is the optimal state for learning and patient education.
But moderate anxiety is where things start to shift.
Right. The perceptual field begins to narrow. The patient has butterflies in their stomach, they're visibly restless, and they suffer from selective inattention. They can still follow directions, but the nurse must actively redirect their focus to the task at hand.
Okay. Then the patient hits severe anxiety and clinical red flags deploy.
Absolutely. The perceptual field shrinks to a tiny pinpoint. The patient is consumed by a single terrifying detail. Their sympathetic nervous system goes into overdrive tachycardia, hyperventilation, diaphoresis, chest pain.
A patient in severe anxiety might literally believe they're having a massive heart attack.
And they cannot learn. They cannot problem solve. This is a classic board exam trap. A scenario will present a patient in severe anxiety and ask for the priority nursing intervention. One of the options will be educate the patient about their new anxiety medication.
And that is always the wrong answer, right?
Always. Teaching a patient in severe anxiety is clinically useless because their brain is functionally incapable of processing new information. The priority intervention is de-escalation. You use short, simple sentences. You reduce environmental stimuli. You focus solely on the immediate physical safety of the patient.
Wow. And if severe anxiety isn't mitigated, it escalates to panic.
At the panic level, the patient experiences a complete disintegration of rational thought. They may experience auditory or visual hallucinations, delusions, or complete dissociation.
What does that look like behaviorally?
They might freeze in a catatonic state, or they might blindly bolt, posing a massive safety risk for physical injury. In a state of panic, the nurse must remain with the patient. You never leave a panicking patient alone.
So you maintain a calm, authoritative presence.
Yes, ensure physical safety and utilize chemical restraints like fast-acting benzodiazepines or antipsychotics. Only if verbal de-escalation completely fails and there is an imminent risk of harm.
That is such crucial safety information. Now, shifting away from the pathology-heavy focus of psychoanalysis and interpersonal deficits, we encounter the humanistic theories.
Yes. Thinkers like Abraham Maslow and Carl Rogers fundamentally rejected the idea that humans are simply bundles of repressed neuroses. They posited that human beings are inherently driven toward positive potential, health, and self-actualization.
As long as their environment supports them.
Exactly.
Maslow's hierarchy of needs is the ultimate prioritization framework for nursing. It is visualized as a pyramid, right?
Right. The broad base consists of physiological needs: oxygen, water, food, sleep, and freedom from extreme pain.
The second tier is safety and security.
Physical safety in the environment and psychological security.
The third tier is love and belonging, intimate relationships and friendships. The fourth tier is esteem, self-respect, achievement, and respect from others.
And the peak of the pyramid is self-actualization, the realization of your absolute, unique potential.
But I have a question about this strict hierarchy. Can someone truly not focus on love or self-actualization just because their safety is threatened? What about the starving artist trope who sacrifices food for their art?
It's a great pushback. While the theory provides a crucial roadmap, especially for nurses who must prioritize a patient's physiological and safety needs before addressing self-esteem, human motivation fluctuates, it's not perfectly rigid in the real world.
But the rule of prepotency still generally applies in a clinical setting.
Absolutely. In emergency medicine and acute psychiatry, Maslow dictates your triage. If a patient is admitted with acute suicidal ideation, a severe safety deficit, and they are also experiencing severe alcohol withdrawal, a physiological crisis, you must stabilize their physiological withdrawal and secure their physical safety before you can ever begin addressing their self-esteem or relational trauma.
A really fascinating dynamic Maslow highlighted is regression during a crisis.
Oh, this is so important for nurses to understand.
Right. Picture a highly successful CEO. They are operating at the peak of the pyramid, focused entirely on self-actualization and esteem. Suddenly, they are diagnosed with stage 4 pancreatic cancer.
Their foundational physiological and safety needs are immediately threatened, so their psychological focus will radically regress down the pyramid.
That sophisticated, polite CEO might become deeply irritable, demanding, and entirely self-centered, obsessing over their pain medication schedule.
Exactly. Understanding regression prevents the nursing staff from labeling the patient as difficult. The key takeaway for the listener is understanding why someone in a medical crisis acts entirely differently than they do in everyday life. The behavior is a natural, predictable response to a physiological threat.
That empathy is so key. And alongside Maslow, Carl Rogers developed client-centered therapy. He deliberately shifted the term from patient to client.
Right, because patient implies a passive recipient of medical expertise. Client implies an active partnership. Rogers believed that clients do the work of healing themselves.
The therapist provides 3 specific things, right? Unconditional positive regard, genuineness, and empathetic understanding.
Exactly. Unconditional positive regard means maintaining a non-judgmental, caring stance, regardless of what the client says or does. Genuineness requires the provider to be authentic and discard the rigid clinical mask. And empathetic understanding means actively striving to perceive the world exactly as the client perceives it.
If the provider supplies the psychological soil, the client's innate drive for health takes over. But while humanistic theories are amazing for establishing rapport, they kind of lack the actionable mechanics required for severe behavioral modification.
They do, and that requires a pivot to the behavioral theories. If humanists care deeply about internal feelings and potential, behaviorists throw all of that out the window.
They focus strictly on observable actions.
Entirely. Thinkers like Ivan Pavlov and B.F. Skinner argued that thoughts and feelings are unobservable and therefore irrelevant to clinical change.
Let's look at Pavlov first. He demonstrated classical conditioning with his famous dogs, salivating to a bell.
Right. He proved that an involuntary biological response can be conditioned to trigger via a neutral external stimulus.
And we see this in humans all the time, right?
Absolutely. This mechanism is the exact pathology behind severe PTSD. A combat veteran hears a car backfire, a neutral stimulus, and their amygdala instantly triggers a massive sympathetic nervous system response, releasing cortisol and adrenaline.
Because the sound has been classically conditioned to the trauma of an IED explosion.
Exactly. Then B.F. Skinner advanced this with operant conditioning, theorizing that all voluntary behavior is learned and driven by its consequences. Positive and negative reinforcement.
Skinner's research on schedules of reinforcement is critical. Continuous versus intermittent reinforcement.
Continuous reinforcement, rewarding a behavior every single time it occurs, is the fastest method to teach a new skill.
I always equate continuous reinforcement to a vending machine. You put the money in, you expect a soda every single time, but if it stops working once, you stop putting money in, the behavior extinguishes quickly.
That's a great analogy. Intermittent reinforcement, however, is insidious. If you reward a behavior randomly and unpredictably, the behavior takes much longer to establish, but it becomes incredibly resistant to extinction.
That's the slot machine. You pull the lever repeatedly, losing money constantly. But because a jackpot might happen at any random interval, the unpredictability keeps the behavior going.
Exactly, which is why gambling is so addictive.
Yeah.
And clinically, this perfectly explains the psychological trap of abusive relationships. The abuser is frequently cruel, but occasionally, unpredictably, they are intensely loving and apologetic. That intermittent reinforcement chemically hooks the victim, making the trauma bond incredibly difficult to break.
So how do we use behavior modification in practice?
In inpatient psychiatric settings, we heavily utilize operant conditioning through token economies, particularly for patients with chronic schizophrenia or severe intellectual disabilities. Patients earn tokens for executing desired behaviors like completing hygiene routines or attending group therapy.
And they trade those tokens for snacks or TV time.
Right. Another powerful behavioral intervention is systematic desensitization, used heavily for specific phobias. You don't psychoanalyze why the patient is terrified of elevators.
You just treat the physical response.
First, you teach them deep diaphragmatic breathing and progressive muscle relaxation. Then you construct a hierarchy of fears. You start by having them look at a picture of an elevator while practicing relaxation.
Then eventually standing near one, then riding one.
Exactly. You are systematically counter-conditioning their sympathetic nervous response. We also use behavioral contracts, frequently in the treatment of severe eating disorders like anorexia nervosa.
A contract specifying a, 0.2 kilogram per day weight gain for unsupervised time off the unit.
Exactly. The behaviorists like Skinner didn't deny that feelings exist. They just believe that if you change the behavior first, the thoughts and feelings will naturally follow.
Action precedes emotion. But behaviorism says thoughts don't matter, which leads us to existential and cognitive therapies, which swing the pendulum back entirely.
Right. They argue that our thoughts, perceptions, and personal responsibility are the only things that matter. Existentialism focuses on authenticity. Deviations happen when a person is out of touch with themselves. The goal is to discover an authentic sense of self and take responsibility.
Branching from this is cognitive therapy, developed by Aaron Beck, and cognitive behavioral therapy, or CBT.
CBT posits that external events do not cause emotional suffering. Our interpretation of those events causes the suffering. It focuses on immediate thought processing and changing faulty thinking to relieve distress.
And a highly specialized offshoot of CBT is dialectical behavior therapy, or DBT, right?
Yes, DBT is often used for borderline personality disorder. These patients experience incredibly intense emotions. DBT focuses heavily on mindfulness, emotional regulation, and distress tolerance.
Then there's Albert Ellis and rational emotive therapy, or RET. He identified 11 irrational beliefs and used the ABC technique: activating event, blank, or automatic thought and consequence.
Right. For example, making a mistake is the activating event. The automatic thought is, I'm a total failure, and the consequence is giving up. RET attacks that automatic thought.
But looking at Ellis's RET and the idea of rational beliefs, I have to push back a bit. Sometimes external circumstances truly are awful. Is it fair, or maybe borderline victim blaming, to say our beliefs are making us unhappy?
It's a very common criticism. But cognitive therapies don't deny that tragedies occur. They focus on what the individual can control, their interpretation of the event.
Yeah.
It's about preventing a single failure or tragedy from spiraling into absolute permanent hopelessness.
That makes sense. We also have Viktor Frankl's logotherapy. He developed this from observing Nazi concentration camp survivors, finding that meaning in life is central to survival.
And reality therapy by William Glasser, which challenges clients who blame society for their problems, urging them to find identity through responsible behavior.
So we have all these coping mechanisms: behavioral, cognitive, interpersonal. But what happens when standard coping mechanisms completely fail? The person enters a state of crisis.
Exactly. A crisis is a turning point producing an overwhelming emotional response. Gerald Kaplan outlined 4 stages of a crisis.
Stage 1 is exposure to a stressor and using customary coping, right?
Right. Stage 2 is when coping fails and anxiety rises. Stage 3 involves desperate attempts at new coping mechanisms. And Stage 4 is active disequilibrium and severe distress.
And these crises fall into 3 categories: maturational, situational, and adventitious.
Maturational crises are predictable lives: marriage, having a baby, leaving home. Situational crises are unanticipated job loss, sudden illness. Adventitious crises are massive social events, natural disasters, violent crimes.
A really interesting point in the text is that a crisis is self-limiting. It usually lasts 4 to 6 weeks and resolves in one of 3 ways: returning to pre-crisis level, growing to a higher level, or stabilizing at a lower, unhealthier level. But why is 4 to 6 weeks the magic number? Is there a biological limit to how long a human can sustain maximum panic?
Your intuition is spot on. The human body and psyche simply cannot sustain peak disequilibrium forever. Biological exhaustion forces a resolution. Crisis intervention, which is highly directive and supportive, is highly effective right at this moment because clients are desperate for relief and unusually open to learning new coping skills.
Okay, so knowing all these theories is step 1. Step 2 is applying them in the real world, which today increasingly means outpatient and community settings rather than long-term inpatient hospital stays.
Right. Inpatient admission is now the absolute last resort, reserved for severe psychosis, active suicidal ideation, or severe withdrawal. Outpatient care allows clients to practice coping skills in their real lives.
And a massive component of that is group therapy. When analyzing group dynamics, you look at content versus process. Content is what is said, but process is how the group behaves, right? Who sits where, who talks to whom.
Exactly. Groups also go through stages. Pre-group, initial, where they're checking each other out working, which involves cohesiveness versus competition and termination.
But regarding the working stage, group cohesiveness is described as desirable. Can a group be too cohesive? What happens if everyone just agrees with each other?
Great catch. The source material explicitly warns about groups becoming overly cohesive. If the implicit goal becomes uniformity, no one gives necessary negative feedback, leading to groupthink, which completely halts therapeutic progress.
The nurse also has to manage group roles, right? Growth-producing roles like the harmonizer and encourager versus growth-inhibiting roles like the monopolizer and critic.
Right. And beyond psychotherapy groups, we have family therapy, education groups, support groups, and self-help groups like AA or Al-Anon, which often have no formal leader.
Modern practice also integrates complementary and alternative medicine, like mindfulness-based stress reduction and biologically based therapies. Plus psychiatric rehabilitation, which helps clients with severe mental illness manage daily living and vocation in the community.
It's all about maximizing autonomy and quality of life.
Well, we have covered an immense amount of ground today. We've traveled from Freud's couch, through Peplau's hospital corridors and Skinner's behavioral tokens, all the way to modern, mindfulness-based community support groups.
And while these theories are foundational for nurses and therapists to provide safe patient care, they are fundamentally frameworks for understanding ourselves.
Absolutely. I want to leave you, the listener, with a final thought to mull over. Look at your own life right now. When you face a stressful situation, do you rely on Freudian defense mechanisms? Do you seek an interpersonal connection like Sullivan suggests, or do you try to behaviorally condition yourself out of it? Understanding your default setting might just be the key to unlocking your own self-actualization. Thank you so much for joining us on this deep dive. Stay curious, and we'll catch you next time.